Sood, who is professor at Dayanand Medical College, Ludhiana, and Dr. Subra Misra is also the third panelist. So now I uh, call upon to Dr. Vineet Ahuja, who is professor at AIMS, Delhi, to speak on active IBD in pregnant lady. Dr. Ahuja, please.
Thank you very much, ma'am. Good afternoon, everyone. Thank you, chairpersons. Now, this is a panel discussion which is about active IBD in a pregnant lady. Are you able to see my slides, please?
No, sir, please share your screen once.
Now it should be visible.
Yes, sir.
So we have three panelists. I hope the panelists are there: Professor Ajit Sood, Professor Rashmi Baga, and Dr. Shubhra Mishra. So the plan is that I'll be asking questions in between. It will be an interactive session all throughout. Now, the very first thing I have out here is that when we talk about active IBD in a pregnant lady, I feel in today's world, this is something where primary prevention seems to have a lot of role. And when I say primary prevention, it reminds me about that there has to be a balance which has to be created between spontaneity and planning. Because in the sense that this is one field which really requires planning, and planning just makes a lot of difference in terms of outcome. This is one area where you can clearly talk about 7 P's. That is proper prior planning prevents poor performance, and that is period. That is I would say the first message which should get across out here. The second message that these are the kind of scenarios which require joint operations. This is like a photograph of air power and joint operations, like you're having high altitude conflict zones right now for India and China. And those are the kind of scenarios where, again, joint operations have taught us that how successful they are. Similarly, when we talk about IBD and pregnancy, one pathological disease and one physiological disturbance, again, out here, joint operation is required. And that is why in the panel today, you have a gynecologist, you have a gastroenterologist, and they're going to discuss about it because I'm sure that each one of them, both of them need to complement each other. Before we move towards a case, I think we need to address certain concerns of the patient foremost. If we are able to address these concerns, I think then we will be able to provide the best treatment possible for such a kind of patient. Often, the patients of IBD, women in the reproductive age group, they have many concerns, and these concerns range from because of IBD can't get pregnant, drugs are harmful, cannot take drugs. The children would also develop IBD. Will they'll not be able to breastfeed? They would always require a cesarean section. So all these concerns, I think, are very important that we address them initially. Secondly, is it uncommon to have pregnancy and IBD combination? No, it is not. Because this is a reproductive age group, this is the ulcerative colitis age group in 20s, 30s, 40s, and you find that there's a fair bit of overlap between them. So obviously, you would get in many cases of IBD women who are in the reproductive age group who would have completed their pregnancy before developing IBD, or biologic with IBD would have developed pregnancy. So let us first address all the patient concerns one by one because I think the concerns of the patient not only teach us a lot, they are most important. So my first question is to Professor Baka. Should pregnancy be advised in a patient with IBD?
The decision for a woman to have a pregnancy is her own, and if she wishes to do so, we can guide her as to how to optimize the outcome. They can undergo pregnancy provided their disease is well controlled and under remission for some time before they plan a pregnancy, and also that the drugs which they are taking, they are the ones which are allowed to be continued in pregnancy, which will not cause any detrimental effects. These are the two conditions. So once she fulfills that and the gastroenterologist says that she's under remission at the minimum possible dose or whatever it is, that is will give her the best outcome. Because if she has a pregnancy when she's in active disease, the chance of flaring up of the disease are to the tune of 70 to 80%. Whereas if she's under remission, the chances of a flare is only about 30 to 40%.
Okay, thank you. So, this is a study which was led by Robert Long from Australia, and there were two Indian centers also in this study, which looked at knowledge and attitudes towards pregnancy in females with IBD. And what was seen out here was that when patients are being followed up in a dedicated IBD pregnancy clinic, which obviously I don't think they exist in India, but we do have multidisciplinary IBD clinics or general IBD clinics, you find that for all these factors, like the questions which I just talked about, a woman with IBD, whether she would like to undergo pregnancy, would she like to try to stop medications and all, you find that most patients, when they are in a dedicated IBD pregnancy clinic or a multidisciplinary IBD clinic, they seem to be more, they seem to have more knowledge about it. As a result, they are able to address these issues better, and the patients definitely seem to benefit much more with the benefit of pre-conceptional counseling. So pre-conceptional counseling is extremely essential. In fact, what you would realize that voluntary childlessness is very high in this age group. It is to the tune of 13 to 18%, and that is because essentially because of poor knowledge. If you look at clear-cut data, we find that the ability to conceive is almost similar amongst patients with Crohn's disease and ulcerative colitis, whose disease is in remission and who have never had surgery. Fertility rates are equal to those in the general population. My second question to Professor Sood, again a concern of the patient. Which single factor is the most critical for a successful pregnancy outcome? Professor Sood, please.
Hello.
Yes, sir.
Thank you.
Just in time, sir.
Right. Thank you so much. I think among the different factors which influence the outcome in pregnancy, it's the phase of the disease what matters the most. If a patient is in remission at the time of conception, I think that is the best time, and that's the strongest factor which will ultimately influence the outcome of the pregnancy. By remission, I mean that it's not only symptomatic remission, but biomarker remission and preferably mucosal healing.
Okay, sir. Thank you. So I'll just take you through some data. This is a study which has looked at long-term disease course and pregnancy outcomes in women with IBD, and this is an Indian cohort study. This is probably one of the largest cohorts from Asia. Just a year back, another bigger cohort than this came up. So this talks about Indian patients and 597 pregnancies. And so, as Dr. Sood told you, that conception can be during the time of remission and conception can be during the time of flare. Clearly, active disease poses the greatest risk to pregnancy. Active disease not only poses the greatest risk to pregnancy, it poses the risk to mother as well as fetus. IBD symptoms at conception lead to IBD activity during pregnancy, whereas IBD remission at conception leads to healthy pregnancy. Hence, the most strategic factor, most critical factor is 3 to 6 months of remission before conception is planned. And that is where I was saying that 7 P's, as I told you, that planning is extremely essential. Now, coming to Dr. Shubhra Mishra. Third concern of the patient, what are the chances of genetic transmission? Obviously, they would like to know that.
Sir, first of all, sir, your sides are not being shared right now.
Okay, but that has to be at your end because I can only share my slides if you. Can you see my?
Yes, sir, now it's visible.
Okay,
Yes, sir, it's visible now.
this is a large cohort of 597 pregnancies in IBD patients from North India. This is, as I was saying, one of the largest cohorts from Asia, and which looked at what happened to these pregnancies and all. And so the pregnancy has been done when the patient is in remission versus a pregnancy when it has been done when patient has a flare. Clearly, active disease poses the greatest risk to pregnancy. Active disease poses the greatest risk to mother and fetus, and IBD remission at conception definitely leads to a healthy pregnancy. So the single most critical factor for a successful pregnancy outcome is not only remission, but at least 3 to 6 months of remission, because that would probably give you the best possible results. So, Dr. Shubhra, what are the chances of genetic transmission?
Yes, sir. So, sir, if you look at the data from the Western population, they say that the chances of a child having IBD in a person whose parents have IBD, single parent, is up to 10 to 15 times more than the general population. And if we look at percent-wise absolute risk, so from Western population, they say that it can range from 5 to 10%. There are some studies which say that the risk is more if the father has IBD. Some studies which say risk is more if the mother has IBD. But if you look at our population, sir, we don't have any prospective studies to which have followed up pregnant women. But we know that familial IBD is present in India in about 4% in Dr. Rupa Banerjee's study, and I think 1.7% in your study, of which around one-fifth had an offspring who had IBD. So I would say at an estimate of maybe 0.8 to 1% of patients might have a risk that their children will have IBD subsequently, and it is more in Crohn's disease than ulcerative colitis.
Thank you, Shubhra. That was very well said. So there are two pieces of data from India which have looked at familial transmission, one from North India, one from South India, and 1.5% in North India, around 4% in from Hyderabad. And if you look at the absolute numbers rather than fold numbers, then you find that the risk of UC is around 1.6%. These are figures which you can like talk about to the patients. Risk of CD is around 2.7%. Obviously, both parents have IBD as a cause of real concern. This may increase up to 30%. But remember one thing, the thing out here which has to be told in addition is that breastfeeding the infant may reduce the risk by 30% for developing. So this is a factor which can be modified. So if anybody feels that, okay, they are going to transmit some genetic risk, part of it can be offset by breastfeeding, and that breastfeeding is also dose dependent, not 3 months of breastfeeding, not 6 months of breastfeeding, but 1 year of breastfeeding. So that is an essential thing which you can. Professor Su, so it's back to you. Does disease activity change with pregnancy?
Yes, I think it's a very important issue, and you have referred to it to an extent. Now, you said that if the conception happens during a phase of remission, and then there are 80% chances that the remission will be maintained, and 20% chance of relapse during pregnancy. These are just, figures. On the contrary, if pregnancy happens with the active disease, then it happens the other way around. That nearly 70-75% of the patients are either likely to persist with the active disease or they may worsen. Means nearly half of them may actually worsen. While one-fourth of the patient, 20-25% patients may improve with continuation of the same therapy. So again, coming to the same point, I want to reiterate again that remission at the time of conception is very, very important, and this should be highlighted. And for this, I mean, preconception counseling becomes a very, very important issue, which I think may not be very commonly done in our kind of setup.
Thank you for highlighting that point. So, Professor Baga and Dr. Shubhra, effect of IBD on pregnancy and neonatal outcomes. Professor Baga, please, what do you think that what effect does IBD have on pregnancy?
So, like we have discussed a couple of times, that a stable disease in remission will have the best outcome. But still, with this problem, we have to start from the first trimester. The risk of spontaneous abortions is higher than general population. Generally, it is around 8 to 9%. Here, it will become about 14 to 15%. Then the risk of fetal growth restriction and the risk of preterm labor. These are two more problems which can occur when a woman with IBD has a pregnancy, which have to be told to her. Then nutritional disturbances. We need to check their levels of iron, their levels of B12, etc., so that we know that they are optimized and that matter that the outcome is better. So because of these three factors, we keep monitoring them during pregnancy. We can monitor them for fetal weight gain, maternal weight gain, then fetal weight gain by ultrasound clinical to see that whether the chances of growth restriction are minimized. And the drugs which they're using, usually they don't have any adverse effects. Most of them can be continued during pregnancy, except for the newer biologic agents. I think that will probably come later in this question. In neonatal outcomes, again, if it is a preterm or a low birth weight baby, less than 2.5 kg of preterm, then the possibility of requiring intensive care becomes higher than that of a normal baby. And breastfeeding, some of them hesitate to breastfeed because they're worried about the transmission of the drugs going into the breast into the baby, and they have to be counseled, like you just mentioned, that breastfeeding has a positive impact on the chances of the baby getting less IBD, to 30%, and the drugs can be given. And then, for example, if she's on corticosteroids, we tell them that take the morning dose and avoid a feed for 4 hours. So the neonatal outcomes and the pregnancy outcomes can be optimized by using the drugs and obstetric management in a planned fashion.
Shubhra, quickly, do you want to add something to that?
No, sir, I think
Okay.
the disease activity.
Add to that, then pregnancy outcome. Ma'am already told you that stillbirth, preterm is something which may be a little bit more, particularly if the patient has had disease activity. And similarly for full term also, it is the same thing. So coming back to you, Dr. Baga, please, is C-section mandatory? That is the query of every patient and also every treating physician. They're all afraid
Yes.
for normal delivery.
Uh, C-section is dictated by the obstetric indications mostly, except in a couple of conditions. For example, if she has ulcerative disease in the perianal area, inflammation where a vaginal delivery or an episiotomy can worsen it, that may be one reason to decide for a C-section. And the second reason could be a woman who's had a surgery, the ileal anastomosis with the anal canal. And there, in sometimes we feel that a vaginal delivery can disturb the area, maybe cause a tear in the sphincter or a problem. So it's a careful inspection of the perineum to decide whether a vaginal delivery can be carried out safely without any damage to the anal sphincter or to the perineum. In those cases, only a C-section would be done for the indication for the disease process. Otherwise, it will be decided by obstetric indication only.
Okay, thank you, ma'am. So as this data from India shows, you'll be surprised to see that in patients who had pregnancy, even after the onset of disease, only 12% underwent cesarean delivery in ulcerative colitis, whereas in Crohn's disease, the number was more. Overall, 10% of patients with Crohn's disease from India, they underwent cesarean section. So the situation is not that bad. If you look at the data out here, you'll find that around 88%, 70 to 80, 90%, they were undergoing normal delivery. So in fact, as Dr. Baga told you clearly that C-section is mandatory only if there is a prior rectovaginal fistula, perineal disease which is present in the form of anal fistula or abscesses, if in case if there's a form anal anastomosis. Otherwise, in perineal disease is absent, then the patient can certainly be sent for vaginal delivery, and the indication for cesarean section will remain like an obstetric indication will remain. But remember, postpartum venothrombus prophylaxis is very essential in these patients. That is not to be forgotten in this. Dr. Sood, please, with the patient wants to ask, does the patient have to stop all drugs? They can stop some drugs. They want to stop all drugs because they're afraid that it will affect the neonate.
Yes,
And if I can add to it, in general, all the Professor Baga has already told that she would not like to stop any drugs, but most obstetricians, we do come across this kind of often a dialogue where obstetricians may advise a session of IPT treatment.
I totally agree that there are differences of opinion regarding certain drugs. Like, if the question is, do they have to stop all medicines? My answer is that they have to continue all the medicines, whatever they are on to sustain remission. Except few drugs like methotrexate or a very uncommonly used drug like thalidomide or mycophenolate. All other drugs should be continued, because if we take a risk of stopping any of the drugs, the risk of disease flare up increases, and the impact of active disease is much more harmful on the neonate rather than the drugs. Now, the often controversy what happens is the use of azathioprine. In spite of a repeated reassurance to the patient that please go back to the gynecologist and request them to continue azathioprine, don't insist on stopping azathioprine. This is a very, very difficult situation. The gynecologists are very adamant that no, we will not take you up for delivery until unless you stop the medicine. So this is a controversy which happens very commonly. I think with time, all of us become more confident in management of the drugs, and I hope at the moment, if I could ask Dr. Baga what is her attitude, her opinion about this, whether she lets continuation of azathioprine easily or not, or with some reservations or not. I think that's important. And all other drugs like biologics, we continue. I mean, there are good data, piano registry and treat registry. there is still inadequate data about the newer drugs like stacrumab or tofacitinib. We may not continue at the moment, but in future we will have more answers to this. But I think controversy about azathioprine should be sorted out in today's discussion.
Over to you, ma'am, please, Dr. Bhagat. Shubhra, you want to take? Okay, you go ahead, please.
No, sir, I'm with Dr. Jeetsood on this that I think we should continue azathioprine. The only caveat is we should not start azathioprine in a patient who is pregnant because there's a higher chance of pancreatitis and cytopenias in the beginning. So if it's going on, then it should be continued, but we should not start. That's the only thing.
Agree.
Professor Bhagat, for the final
So-
word of reconciliation.
Preconceptional counseling really becomes important here because whatever medication she is on at that time and she is well controlled in remission should be continued during pregnancy because a relapse is going to worsen the outcome in whatever way. So there is sufficient data on azathioprine use, maybe not in this condition, but in other conditions, for example, renal transplant recipients, and it is to be continued at the lowest possible dose which she requires to sustain her remission. So there are other drugs also, 5-ASA, that is also to be continued, and folic acid supplementation should be given with that to reduce the risk of side effects on the fetus. And the newer biologic agents can also be given. The only drug which is not to be given is methotrexate, which should be preferably stopped at least 3 months before she plans the pregnancy.
Thank you, ma'am. I'm happy that the obstetricians have at least agreed to starting azathioprine the lowest possible dose. There's still one caveat out there. And just to point out, there's a recent study, till now azathioprine data has been retrospective, but very recently a prospective data on azathioprine has come up, whereby this paper came up in gastroenterology recently, which looked at patients who were on azathioprine, who were on TNF, who were on combination, and overall it suggested that there was no increase in congenital malformations, spontaneous abortions, preterm birth, low birth weight. The only increase happened if the patients were not in remission when they were planning pregnancy. So that still remains the most important factor. Otherwise, this large prospective data set clearly suggests that azathioprine can be used. Biologics, Dr. Sood has already answered. He has clearly told us that benefits of treatment for pregnant women far outweigh the risk, so no treatment should be stopped. And Shubhra pointed out this point already, that if you're starting thiopurine therapy for the first time in pregnancy, do not do it for the risk of pancreatitis, leukopenia, and delayed time to act. And the second point is, when you're giving maintenance therapy, both the speakers also, so all the three speakers said that try to give the drugs which are really required. So monotherapy should be given. If a patient is on azathioprine plus infliximab, you can easily stop one of the drugs. And this is a table which talks about not only the use in pregnancy, but also in breastfeed, and shows that sulfasalazine is not preferred. 5-ASA would be preferred. Steroids are safe. Azathioprine is safe. Infliximab, adalimumab safe. So ustekinumab and vidulimab, we have limited data. Methotrexate, unsafe. Cyclosporin, preferably not to be used, and also not to use tofacitinib at all. And allopurinol also not to be used. And again, safety during pregnancy can be through all the 3 trimesters. It is not that you have to stop by the 3rd trimester, as was the teaching maybe a few years earlier. Now, data clearly suggests that you can also give it in the 3rd trimester. It is just adjust the dose so that it's a little bit far away, in the sense the maximum interval between the delivery time and the dose. That is the most important thing out here. Now, I think we have added the 10 minutes of discussion time also to this panel discussion, because this is interaction is already going on. So now let me come to the case. We have already talked about what the patient wants to know. So that if a lady comes first trimester pregnancy on 5 years of
Hello. Hello.
Dr. Sood, are there any more questions you'd like to add out here? Can help us. Certain other nuances which we can talk about.
The sound is breaking out. So the question is that the first trimester patient has a severe disease and is not responding to 5-ASA and azathioprine. Then I think question is the use of steroids. Options are biologics or surgery. So steroids can be used during pregnancy and in short spells. They are not harmful. They can be a good choice. And in case of steroids fail, then we can go to biologics. And of course, surgery can also be planned in case, depending on the situation, if there is an indication like toxic megacolon or massive hemorrhage, we can still consider surgery. But the risk of spontaneous abortion is not that this is higher if any procedure, surgical procedure, has to be done in the first trimester. But steroids and biologics are safe even during the first trimester. Of course, we need to optimize the dose of 5-ASA and azothioprine before we say that these drugs are not effective.
Thank you, sir. So clearly, as Dr. Sood pointed out, that you can give steroids, you can go in for infliximab. Adalimumab, remember, would not be effective in acute severe ulcerative colitis, but if it is a case of Crohn's, you can give adalimumab. Vedolizumab, again, there's minimal data on pregnancy. Acute severe ulcerative colitis, it may not act. Cyclosporin avoidable, tofacitinib contraindicated. There are certain nuances. Serum, don't judge inflammation out there by serum albumin, as it may spontaneously fall by 1 gram. ESR in first trimester may rise by 2 to 3 times because of pregnancy. So CRP would be more accurate. The best would be fecal calprotectin. And sigmoidoscopy can be done, but do it unprepared and unsedated. And venous thromboembolism prophylaxis has to be given. If the patient has CMV infection, remember you cannot give ganciclovir or valganciclovir. There you will have to really taper down the steroids or give CMV immunoglobulin. Clostridium difficile, oral vancomycin can be given. Surgery, if required, yes. So lactation, I think we have had talked about. And my last question is, can pregnancy be beneficial for patients with IBD? Short, quick, yes or no? Professor Sood first, then Professor Bagga.
Besides having a pleasure of being a motherhood, there are medical grounds. If you say we can't suggest a patient who's not doing well that okay, you conceive, you'll improve with the pregnancy. That statement may not be right, but there are few reports in which pregnancy has helped in improving the clinical state. But overall, if we see, again coming back to the same question, that depends, the outcome of the pregnancy and the course will depend on the basic on the kind of the phase of disease at the time of conception. I will definitely encourage patients to conceive.
Okay, thank you, sir. Professor Bagga.
Pregnancy is a physiologically a very happy stage of life, and having a baby will have a very positive impact in a patient who is unwell with a chronic disease. So, if the patient can be managed and optimized by a gastroenterologist, and pregnancy can be carried through, it is likely to have a good impact on her. And there are reports which say that multiple pregnancies in women reduce the exacerbations of this disease over years of time. But then again, they are not maybe because of pregnancy, they may be because those are healthier women who had no difficulty in conceiving or having a live birth.
Okay, ma'am.
So, if a patient desires a pregnancy, she should be encouraged with multidisciplinary management in a tertiary hospital.
Okay, ma'am. Point well taken. Again, coming back to the Indian cohort study, we looked at patients who had before IBD, pregnancy after IBD, and looked at the disease course. It was clearly seen that patients who had pregnancy after IBD, they had a much stabler disease as compared to patients who had IBD and never achieved pregnancy. So clear, there's a TH polarization which occurs. In fact, if you look at the three case scenarios, we find that if a patient of IBD goes on to develop pregnancy, possibly the patient has a benign disease course. Obviously, there can be a confounder, as Professor Baga pointed out, that some of the patients may automatically have been doing well. So clearly, you see that when we talk, earlier we talked about that pregnancy, whether to advise in a patient with IBD or not, as you are esteemed panelists, they've clearly enlightened us. It's a case of going from hopelessness to hope. And then there's a lot of hope out here. It's a question of open windows and closed doors. The patient of IBD feels, okay, they will not get pregnant. What will happen? Genetic transmission and so on and forth. No, it's a case of open windows, closed doors. And in fact, we have all myths have been busted that the patient can get pregnant. They have the same kind of fertility rates. They can take most of the IBD drugs. The genetic risk is not so high. They need not have a cesarean section. And besides that, I think it also highlights a point that you need an integrated command out here. You need a joint effort out here. And this is what Indian Express today talked about Chandigarh, smart city Chandigarh, the smart people from PJ and Chandigarh, that you need an integrated command center. And with this, I end by saying that whenever the final slide for the residents contemplating pregnancy, review medication safety, stop methotrexate or tofacitinib. Medication should be compatible with pregnancy. Then you assess the disease activity and advise them to undergo consultation only if the disease is quiescent at 3 to 6 months. If the patient is active, I will treat it first before the patient is advised conception, and thereafter, once you are going being done, then you also discuss the delivery modality, active perianal disease, cesarean section, neither perianal disease or anything, then the patient can go for vaginal delivery. If there's an IPA, then again the high chances of cesarean section are there. With this, I thank all my panelists, and I'll just quickly take a question thing. So the questions are.
Vineet, if I may just come in, please. There were a couple of questions in the
Yes.
box. And I think one, of course, is partly covered: onset of IBD during pregnancy, how to approach, and what would be the outcomes. I guess the outcomes are covered, but how to approach would be another issue if the lady gets diagnosed for the first time with IBD during pregnancy.
So, Professor, please.
I think there are two things. The counseling is very important. We have to concentrate on the medical therapy. We have to tell a person that all drugs should be continued, the drugs which are on, and if she is in remission, we should continue the drugs. In case if she has active disease, then we should try to optimize the drugs. And if we need to add on, we should, and avoiding azothioprine as a new addition during pregnancy. Besides drug, we should concentrate on the nutritional status of the person. That's another important issue which Dr. Baga did refer to. So these are the two things, and we should talk to the patient and tell them that she is very capable of continuing with the pregnancy, and she will safely continue till term. And the delivery will also be normal. We have to talk to the patient, and counseling is very important in such a situation.
I guess we are running late. Haven't we exceeded the time? If we have,
1 minute.
No question. Okay, so we can. There's another question. I think the relevant would be: does the choice of steroid change during the first trimester of pregnancy? Would you prefer hydrocortisone or methylpred? What would be your choice of steroids in case there is a relapse of the disease?
For ulcerative colitis, see, we have recently got controlled this MMS technology of budesonide that is effective in ulcerative colitis if it is a distal disease. Otherwise, controlled release budesonide is not effective in ulcerative colitis. So there we have no choice. And that again will depend on the severity of the disease. If disease is moderate to severe, then we have to use prednisolone. If disease is mild to moderate ulcerative colitis, if we have MMX technology of budesonide, we can still consider that. For Crohn's disease, ileal disease, we can use budesonide for mild to moderate, but for moderate to severe disease, we have to use prednisolone or injectable.
Yeah, I guess
we have exceeded the time, so we can end this session here. So I want to thank Dr. Vineet Ahuja for this excellent moderation, and I want to thank the panelists, Dr. Ajit Sood, Dr. Rashmi Baga, and Shubhra for this excellent session. So now the next session is on the CBD stone and cholangitis in pregnant lady. The moderator for next session is Dr. Pramod Garg. He's a professor, Department of Gastroenterology, AIIMS, New Delhi. The panelist for this session is Dr. Vinita Jain. She is professor, Department of Obs and Gynae, PGI Chandigarh. Dr. Sandeep, professor and head of gastroenterology, SMS Medical College, Jaipur. And Dr. Anurag Jina. He's a senior resident in Department of Gastroenterology. I will request the moderator and panelists to please stick to the time. Over to Dr. Pramod Garg.
Thank you. I would like to thank the organizers, particularly Professor Usha Datta, for giving me this opportunity to discuss this important topic of CBD stone leading to cholangitis in a pregnant female. So this session I know is on